We routinely use teriparatide for 3 to 4 months in a rheumatoid patients, but we don't use DEXA scan objectively. On the table, we see osteoporosis. Sometimes bones are so soft. Are we justified in putting teriparatide for 3-4 months without an objective DEXA scan?
That's a great question. And we do it all the time off label for, fracture healing and adjunct fracture healing. I would say that a rheumatoid patient, to your point, a DEXA is very imperfect. You really have to correct the DEXA, by 0.5. So they may actually meet the threshold for osteoporosis with those corrective factors, and therefore I would treat for longer with the teriparatide. But getting 3 to 4 months in perioperatively, that's really when the anabolic window is widest open. So you're doing something good, but you may be able to do more if you do it for longer.
So Mike, Elena, question to you. 2 questions. One, going forward to what Guru was said, that surgeon assessment of the quality of the bone, we did a study and correlated with DEXA, and it is excellent. In fact, one can use that. The study at the moment is with the journal for publication, and you can use it to start the treatment after total knee. The question is about the vitamin D supplementation. The ideal dose of 1000 or 2000 per day somehow doesn't work, or at least in Indian population. You go on for months and nothing happens to their whereas what we showed that one single high dose, which is 6 lakhs international unit, which is normally given intramuscularly, but we give it orally so that you never reach the toxicity dose, gets your vitamin D level up in 3 days time, and then you can maintain with the smaller doses.
So what are your thoughts, Elena?
So we've moved away from those mega doses. Yes, you get the serum value up, but it has a negative impact on other metabolic parameters. And then on microarchitectural CT, you actually, the high resolution one, you actually see it's not as favorable. So yes, when somebody's deficient, what we will do is give 5,000 IU daily, usually for 6 to 8 weeks, depending on how low they are, and then move to the maintenance dose. But yes, that is a maintenance dose, not topping up the tank. But the way that I sort of characterize it to patients who want to get off their weekly vitamin D, which was standard of care, is you want a suntan, not a sunburn.
Right. So microphone 2.
Yeah. So my questions to Elena. So yeah, here.
Yeah,
so my question
you're
is
popular.
So my question is, what is your preferred drug like bisphosphonates, teriparatide, or denosumabs after TKR to prevent osteolysis?
So let's have
and
short
duration
answers,
and dosage, both.
Short question.
Duration and dose.
Depends
as per
on the
data.
patient, depends what's available. Probably if I have to choose, I always start with an anabolic.
Okay. And how long duration?
Usually we use the anabolics for 2 years.
2 years. Okay. Thank you.
And what dosage?
Teriparatide is a fixed dose, 20 micrograms sub-Q per day.
Okay.
Okay, perfect. Yes, microphone 1.
Yeah, I'm Dr. Shetty from Bombay. My question is to Dr. Amar Ranawat, a consensus on tourniquet. Can we have a consensus when to use tourniquet, when not to use tourniquet, and what are the
So how many in the panel use a tourniquet regularly? How many of you use it only up to cementing and deflate it?
Yeah, so I do my exposure without the tourniquet. I think it's a skill that needs to be learned so that I can do it. If I do a non-cemented case, I'll never turn it up. If I do a cemented case, I will selectively turn it up for cementation.
David?
I don't even have one on the leg. I have one in the room, a sterile tourniquet available if needed for an emergency.
But routinely you don't use it.
Don't even put it on the leg.
Sunil?
Yeah, deflate it after cementing, don't use a drain.
Deflate after. So from incision to cementing. Yes, Harish?
The question to Alana, the 3 options of treating osteoporosis, the alendronate derivatives, the denosumab, and a teriparatide injection, can they be used together? And if you use together, will they enhance each other, or would they acting against each other?
Guys, this is an
Excellent
arthroplasty
question.
meeting, but anyway.
Excellent question. We do not use things together. The only thing rarely we will use together is denosumab and teriparatide in very unusual circumstances.
What's the reason?
They do not work synergistically. One attenuates the effect of the other.
So if you have to use one of the 3, which is the best one in case of osteoporotic patient I am treating for, say, TKR or THR?
So I always start with the anabolic teriparatide, and then you move to the anti-resorptive once the 2 years are over.
And you give it for 3 months and
Yes,
then do the
yes.
surgery?
3 months or 2 years ideally.
Harish, over tea time. She's going to be right here. So reserve your questions for tea time for Elena. We have other panelists as well. I'm just joking, Elena. Yes.
Good morning. My name is Dr. Tarun Khare. I have one question. We usually evaluate patients for TKR for cardiac status.
Yes.
Post 60. But if there is a inflammatory arthritis who is planned for TKR, do we go for cardiac status or hypercoagulable state in those patients?
Yeah, so I would answer this by saying that all patients need assessment. Rheumatoids, especially you're talking about the inflammatory arthritis, definitely need more because they have a higher risk of cardiovascular complications because of the various drugs they are on. So I would say yes. Any of the panelists would say that there is no need for doing in younger patients a cardiac evaluations, or how do you approach an inflammatory arthritis patient, Amar?
Yeah, I mean, I think the simple way to think about it is they're physiologically older than their stated age, right? So you don't want to underestimate them. And you know, there are varying degrees of rheumatoid arthritis. There's severe, right? There's RA factor positive. So they're multi-joint, single joint. So I think the more involved they are, the more likely they have a vasculitis, the more likely you should, work them up for everything.
Microphone 4, number 4. Yeah, go on.
Yeah. Good morning, I'm Dr. Iftikhar. So my question is regarding the DVT prophylaxis. Do you use same aspirin and simultaneous bilateral total knee arthroplasty, or you change your protocol to some
So
other?
great question. Does your DVT prophylaxis differ for unilateral and bilateral? Let's start. Dr. Yadav, I know you have some out of the box views, but nevertheless.
When I started my independent arthroplasty.
Yes, answers. We just have 3 minutes. Amar will get mad at us.
It will be same.
So what do you use? Let me ask that.
DVT pump and aspirin.
DVT pump and only aspirin, unilateral, bilateral, same. Dr. Vaidya, you just gave us a talk. Quickly tell us what you use, unilateral, bilateral.
Within 2 hours with pain management, number 1, aspirin and pneumatic compression.
So uni and bi both same. Amar.
I would like to use only aspirin, but then I get these letters from my hospital saying I'm not following the guidelines. I personally believe, if you want to hear my beliefs, I personally believe the idea of prophylaxis after hip and knee replacement now is a thing of the past. We should only treat people who are having problems.
David.
Aspirin, and I just write a note in the chart that says that I'm going against the guidelines.
Sunil.
Aspirin 2 weeks unilateral, 3 weeks bilateral.
So everybody in the panel uses aspirin. How many of you in the delegates use aspirin routinely? Yeah, great. So Thorsten, tell us what happens in Germany, because I think you are bound by certain laws and legal situations. Can you tell us what you use in Germany? By the way, welcome.
Yeah, thank you so much. Unfortunately, we are forced by our government to use low molecular weight heparin because our guidelines don't allow. They do not allow.
If let's say the government was more liberal and democratic and they let you do what you want, what would you use?
I would use, if I could, aspirin, of course.
Aspirin. So there you go. I think that's probably coming out as the wonder drug. So aspirin. Yeah. Microphone 3.
Yeah. CKD patients, what is the recommendation for DVT prophylaxis and bone metabolism as well?
So CKD patients, does it differ? Anybody? Sunil, David, anything different? Amar?
CKD, is 1, 2, 3. They say almost every patient has CKD 3. And you look at them, they're normal. They go crazy. You can't put an NSAID on someone with CKD 3. And their kidney function is just a little bit above, normal. So I think if we're talking about 3 weeks, 6 weeks, I would just ignore it, but,
Yeah, microphone 1.
Yes. Hi, Dr. Maiman, have you tried using any surgeon-administered adductor canal blocks, or does anyone else use those?
Surgeon administered meaning the surgeon giving it?
Yes, so through the arthrotomy, it has been described in multiple techniques.
So you put a catheter, you mean, inside?
No, just a single shot injection.
Okay.
Yeah, so there are a lot of surgeons. We don't at HSS, our anesthesiologists do all of these blocks. but there are very well-described ways for surgeons intraoperatively to do an adductor canal block that have been very effective. So I think that's a very reasonable way to do an adductor
Yeah, just
canal
quickly
block.
on that note, how many of the panel don't use steroids in their cocktails? Don't use steroids. So, do you have, David, in your practice, certain subset of patients in whom you would avoid steroids?
Yeah, so I don't use steroids in anybody that I'm worried is high risk for infection, so the inflammatory arthritis patients.
Okay.
Or
Diabetics?
Diabetics.
Okay, so I think that's a good message. Don't hesitate to use steroids. You know, as Dr. Ranawat used to say, 5 milligrams of steroid is not going to kill a patient. So I agree with that. And it really keeps the inflammation low and the patient has a great recovery. Microphone.
Yeah, this is Dr. Khare. I just wanted to note from the panel, what is the exact dose of aspirin to be given to
Great
the patient?
question. Let's start with
how long?
Anil. What do you use?
Aspirin 75 milligrams.
Once or twice?
Once, sir.
Yes, David.
81 milligrams twice a day.
Amar.
81 milligrams twice a day, and people who are on 81 to start with, I'll go to 325 twice a day.
325 twice a day. Oh, that's a good point.
75 milligram after dinner every day.
Once a day.
Once.
Yes, what about you, Dr. Vaidya? 75 once a day. I think that's a little bit of a confusing issue. How many in the delegates would use 2 doses, let's say 75 milligrams twice a day? Once a day? So I think that's what majority. Okay.
Can I just tell a 10-second quick story?
Yeah, 15 seconds.
15 seconds, all right. So Paul Lotke in the United States was the first person, he's a surgeon in Philadelphia, first surgeon to be the proponent of using aspirin for DVT prophylaxis in knee replacement. So speaking to him one day, I asked him, why 325 milligram twice a day? Because that was his dose. And his answer was, it was only available as 325 milligrams, and if I told them to take it twice a day, I thought they'd take it at least once. So a single aspirin once a day is as effective as any other dose.
Anybody uses drugs like the factor 10A inhibitors, Epixaban, or anybody uses Eloquus? What is that?
Yeah, we have guidelines that, make us use them in bilaterals, in patients with BMI over 40. I don't even know all the guidelines because I break them all the time.
Rajesh, a quick comment, and
Yeah.
we have 4 more questions, then we
I
stop.
just wanted to talk about the adductor canal block. We have 3 very good papers from India.
Sure.
Bagaria did an anatomical study.
Sure.
Nilen has done a clinical study.
Sure.
We've published in JOA.
So what's the
It works very
consensus?
well, takes 10 seconds more. Every surgeon should do it.
Okay.
Intra-op adductor canal block.
Great point. Yes,
Yeah.
microphone 2.
BMI over 40, no stem, short cemented stem or a long uncemented stem?
Amar.
I would use a standard implant.
No stems at all, but those of you who use stems, which one?
So depends
Short
on
cemented or long?
depends on the implant that you're using. You need to know your implant, but if I was using a stem, it would be short cemented.
Why is sir?
120 mm attached to the base
But
plate.
uncemented, cemented, the long stem is uncemented?
Cemented.
Even the long stem?
Yes.
Okay, that's good to know. Yeah, microphone 3.
Myself, Dr. Mohammad Arif. My question is that if patient preoperatively have on steroid, then what is the protocol after the surgery and intraoperatively?
So, patients on steroid because of rheumatoid or any other
Any
reason?
inflammatory disease like
Any
SLE,
inflammatory disease. So, as I said in the guidelines, I think you should try to reduce the dose if the patient is not steroid dependent, and during the perioperative period move to IV if the patient is on oral, and don't stop it at all. You should definitely continue.
You should
it.
continue on the
trend
second day.
is to not stop it, not give them stress also, and just sort of continue it.
Absolutely.
And my second question is, if the patient, when we start the aspirin, on day 1 or day 2nd?
Day 2nd, the 2nd day of surgery you start aspirin. Yes.
Yeah. My question is regarding the steroids used in cocktails. Now, if you are giving an intraarticular steroid prior to the surgery, we have to wait for a couple of months, probably a month or so, and then we do the TKR. Then how does that
So the question
justify?
is intraarticular steroids, which is very commonly used in India and I would say in the US as well. When would you subject that patient to TKR after receiving the last dose? Yes, David, I know, I can see a smile on your face.
So the guidelines say 3 months.
3 months.
The data is poor. There are big cohort studies. The data is poor. I'll do it after 8 weeks.
8 weeks.
But the guidelines are 3
So my
months.
exact question is, now we are using steroid in cocktails.
Yes.
And then we have to wait for 3 months.
I agree, it doesn't make sense.
Amar.
Doesn't make sense.
It doesn't make sense. One has been, a clinical observation that it has not been a problem. I will inject total knees with steroid that are having a synovitis after I rule everything else out, so I've done that. Yes, I think, infection is such a bad risk that I would advise people to wait, in my practice, minimum 8, otherwise 12 weeks before they have their surgery. Because the data is there, but we don't know what time point it is. It could be 4 weeks is fine.
Yeah.
Most people have these 3 months check marks, so that's why.
So Kailash, I would differentiate a little bit between patients with intraarticular steroids. They tend to get depositions on the articular cartilage.
Yeah.
So you see it's very different than putting an intraarticular steroid. So it doesn't really, comparing, it's not like comparing apples to apples. So absolutely. So, one can think of still doing it, but they have those depositions and they behave a little differently.
Recurrent steroids they will have.
Yes. Microphone 4.
So I am Dr. Dhananjay Deshmukh. My question is, have we came across those patients who are more prone for DVT having raised serum homocysteine levels?
Yes, Elana. Raised homocysteine levels.
Raised homocysteine levels we, treat with folate and B12. That's essentially to
Is
bring it
that
down.
the question you
Yes,
you got the
because,
answer?
I do not think-
because post-COVID we had found patients who are having DVTs, they are having raised serum homocysteine level.
Right. So
Well, it depends when you measure the homocysteine. Is it pre-op or post-op? Because it can also be like an acute phase reaction. So that it's a little bit complicated. But generally speaking, when I see a patient, I do all their vitamins, and I usually know if there's a B or a folate deficiency, raising the homocysteine, and then we correct that pre-op.
The second last
Yeah.
question.
So my question is, do you routinely do as a part of pre-operative workup CRP levels, and what is the cutoff CRP levels for rheumatoid patients, as there is always high CRPs in those patients?
Anybody wants to take that? So I can answer it. We
Yes.
have to do it routinely. ASR, CRP, it's a part of the pre-operative protocol. If it is alarmingly raised in rheumatoid patients like 4 times, 4-fold, and the patient has symptoms of exacerbation and he has a flare-up, then I would correlate the value with the clinical findings and then delay the surgery.
But there is no exact value as such.
4-fold increase. That's what the
Fourfold.
literature says.
Okay, thank you.
CPR, I don't think any clinical relevance there, Parag. It's a more a theoretical risk, but I do routinely without bothering about CPR.
Okay.
All the rheumatoid patients.
Yeah, that's what I said in the
Yeah.
session. It's ultimately your decision, but there are certain guidelines which are there. Last question.
Dr. Ramteke from Nagpur. This is a question for Dr. Alana and rest of the panel. So we have a lot of patients who get bisphosphonates for a long period of time, especially for AVN. So does use of bisphosphonates interfere with osseointegration, especially in uncemented implants?
That's a great question. We used to think yes, and we used to think that there was, impairment of fracture healing. That is not the case. So it doesn't, it can actually improve osteointegration and it does not impair fracture healing.
Yeah, last quick question and a quick answer.
We have seen, we have been using aspirin in low dose of approximately 75 milligram per day. We have seen Indian patients having ecchymosis, even that post-op, even in that low dose. So does the panel recommend the 325 milligram dose for that too?
No, so if it's low and you're getting ecchymosis,
Yes,
why are you
so-
asking for a higher dose?
No, that is what I'm telling. What's the viewpoint of the panel in
Okay.
that?
We're trending towards the lower doses now.
So are you trying to say that the lower dose has less ecchymosis or something?
No,
Was
no,
that
what I'm
your,
trying to say is that even in that low dose, we are having patients having ecchymosis.
Correct. Okay, so anybody else has anything on the dosage of aspirin before we conclude?
Parag, just one word. Aspirin 81 milligrams is available in America.
Not here.
Not here. We did a study with University of Florida. We flew the drug
Okay.
with a special pharmaceutical permission, and we did around almost 1,000 patients, prospective randomized. 81 milligrams single dose is as efficacious as the other dose. We are not
Okay.
yet published, yeah.
Yes, so that's a great point, and on that note, I want to thank the panel